So thank you, Federica. Just as a brief introduction, this webinar series was planned by the EuSoMII Education Committee. The idea is to have a presentation, a monthly presentation of AI across different subspecialties. This will be jointly organized with relevant societies of each subspecialty. So we are really happy that, and we think that this will encourage dialogue between societies and presentations from different perspectives that will clearly will be enriching for everyone. So we are really happy for the series itself. Today we have the pleasure of having this collaborative session jointly organized with ESGAR and centered around AI in abdominal imaging. So I will introduce first myself. I'm Mercedes Serra, and I'm here with my friend and colleague, Federica Bernuccio. We are happy to moderate this session. We are part of EuSoMII Education Committee. And we have the pleasure to welcome today Roberto Cannella, that for this specific session will be representing ESGAR, though he's part of EuSoMII also. And he will discuss mainly on the clinical perspective of AI in abdominal imaging. And then we will have Annalita Pecchi representing EuSoMII, who will focus on the more technical aspects of AI in abdominal imaging. So during the presentation, we will have two 20-minute presentations, and we will have a QA discussion at the end. Please don't hesitate to post the questions during the presentation using the Q&A function. We will select questions to have a rich discussion at the end of both sessions. So this is specific separate function from the chat. You will find a Q&A function on Zoom at the bottom toolbar. And this is mainly it. I will have the pleasure now to welcome our first speaker, Dr. Roberto Cannella. He's an assistant professor of radiology at the University of Palermo, Italy. He's a fellow of ESGAR, serves on the Young ESGAR Committee, and is a board member of EuSoMII. Dr. Cannella trained in Palermo with international experience at the University of Pittsburgh Medical Center and Bougon Hospital in France. His research focuses on abdominal and hepatobiliary imaging, hepatocellular carcinoma, and artificial intelligence. Now, without further ado, I'd like to invite Dr. Cannella to discuss clinical perspective of AI in abdominal imaging.
Good afternoon, everyone. It's really my pleasure to be here and to represent ESGAR and also in this ESGAR EuSoMII joint webinar. I think it's a great initiative, and it is really my pleasure to start with this presentation, which will be AI in abdominal radiology. And I will mostly focus this presentation on the clinical perspective, speaking about clinical applications and also what we can expect from a clinical point of view from the AI, but there is even much more regarding the technical details, and I will left all these points to the presentation of Annalita Pecchi. So those are my disclosure. Regarding the clinical application in abdominal radiology, I will mostly focus on four main points, and those points regard the image interpretation, the workflow optimization, the automatic measurements, and the structural reporting. Those are all part of our daily practice, which can be difficult or can be time consuming, and we'll see how the AI could potentially help in this work, in this part of the abdominal radiology in our daily job. So I would like to start with some cases regarding the clinical interpretation, because clinical interpretation of abdominal imaging is not easy. We can face many types of errors and challenges during abdominal radiology, which can be related to the presence of small lesions, multiple organs, or different pathologies or interpretation on different pathologies. And now I'll show you here three different CT images from three different cases. And do you see any relevant findings? Because sometimes there are stuff that we may overlook during our clinical practice. And let me show you that these were all findings that were overlooked by the initial readings, like a small lymph nodes between the aorta and inferior vena cava, a pancreatic head abnormality, or a nodule in the peritoneum. And they were all related to be clinically relevant findings. So sometimes we have challenges in interpretation and challenges in findings the main pathology during abdominal imaging, which could be related to the interpretation itself and the location of the lesion or the satisfaction of search. But we can have also challenges in naming which type of lesion are we dealing with. And here I'll show you another example where potentially imaging informatics, AI, radiomics could help to our diagnosis. And this is a case of a lady with a lesion in the left hepatic lobe. And my question is this an hemangioma? Because this was initially read as an hemangioma, but the patient underwent follow-up and the lesion grew in size, showed more heterogeneous enhancement, and this was proven to be a cholangiocarcinoma. So this kind of imaging interpretation is related to which is the diagnosis rather than to find the specific lesion. In all this setting, the AI could help us for providing the diagnosis and providing the localization of the lesion during abdominal imaging. Those are some of the applications that we can expect in the future regarding liver imaging, identification of the lesion, assistance in the categorization of the lesions, for example, assistance in the Lyras categorization, which is used to categorize lesions in a cirrhotic liver, identification and stratification of chronic liver disease. We are moving more from a qualitative imaging to a quantitative imaging analysis, as well as in the pancreas, detection of early lesions in the pancreas, early cystic lesions and solid lesions. And believe me, could be really challenging because the pancreas is often overlooked during the abdominal imaging or assessment of acute pancreatitis, but also in renal and the urinary tract. We can use AI to differentiate cystic lesion from solid lesion or LPAS to the stone analysis and stone composition of stone analysis. And also in the gastrointestinal tract, there are studies evaluating the performance of AI to enhance the polyps in identification and also other bowel pathology. So those are all potential applications that we may expect to have in the next years. What do we have right now as application in abdominal radiology? Well, there are the first studies coming on abdominal imaging. I have to say that regarding the abdominal application, there is some still challenges for the use of the AI in abdominal imaging. First of all, because abdominal imaging is complex, there are multiple organs, there are multiple phases, even on ACT. This is a really recent study published on the AI assistance with the Lyras classification. And what they did, the author, they read the abdominal MRI without the use of artificial intelligence and with the use of artificial intelligence, which localized the lesion, but also provided an assessment of the imaging feature using the Lyras algorithm. And what is interesting to note that in this study, the overall accuracy increased with the use of AI, and this was a significant findings according to the statistical analysis provided by the authors, but they also stratified the accuracy according to the experience of the radiologist. And with junior radiologists, we saw the highest improvement in the accuracy for the large classification, and also for senior radiologists, the accuracy improved from 76% to 80%, so a smaller improvement, but still significant. And I think this will be one of the potential applications of AI imaging, which could help us in the clinical practice and image interpretation of those lesions. But this can be virtually applied to all the organs and all the pathologists, and why the technology will improve and the diagnostic imaging will expand with the use of the AI. Look at this example. This is a IPMN which grows over size, and we know that this could happen. And also part of this lesion have high-risk stigmata or worrisome features suggesting malignancy. So application in pancreatic imaging and pancreatic cyst have already been explored regarding diagnostic model, so prediction of malignancy in pancreatic cyst, prognostic model, automated detection, which is not easy when, for example, we look at an emergency CT of the abdomen and our focus is not the presence of pancreatic cystic lesion, and also automated size comparison. Size is one of the key criteria to categorize IPMN, and oftentimes we have very small changes of the size of the lesions, and automated size comparison could help us to estimate the progression of the lesion during time. What about radiomics? Radiomics is a more complex field for the application in clinical practice. There have been tons of studies of radiomics in liver imaging, pancreatic imaging, and all abdominal diseases. Radiomics has the potential to extract a large number of features from the images, from the tumor itself, and the peritumoral parenchyma in order to construct models that can help to predict the pathology, they can help to predict the clinical outcome or the therapeutic response. And there have been several studies exploring the role of the radiomics in abdominal imaging. I will mostly focus on the liver because it is my main topic of research, but those applies to all the abdominal organs. And radiomics model can be used to construct models and predict, for example, the histology of the lesion, of the survival of the patients. But also very explored is the comparison between the radiomics feature and immunological profiles of the lesions and also genetic profiles. So we can merge all together this data and compare the so-called radiogenomics, in which we merge features extracted from radiological images, genetic data, histopathological data, and also immunological data to improve the prediction of the model. The problem of radiomics is the reproducibility and also the very high heterogeneity that we have with current radiological images. This is a systematic review that we performed 2 years ago, thanks to the EuSoMII Radiomics Auditing Group initiative, which is a group focused on the understanding and improving the quality of research in the radiomics analysis. And what you can see from this systematic review, was applied to cholangiocarcinoma, that there were a variety of studies exploring the role of radiomics in cholangiocarcinoma with a variety of aims, and not many studies were assessing and there were prior models developed by the authors. If we look at the quality of the current radiomics studies, there are still problems that prevent the larger application in clinical practice, and those problems are related to the lack of prospective studies and to the lack of studies assessing reproducibility of radiomics, and also lack of open science data. So the author published the model, assessed the model, but it cannot be applied in other institutions and other settings. And this is applying to all the fields of radiomics. This is a very interesting systematic review regarding the application of radiomics in pancreatic imaging, and you can see already from this table how many different applications of radiomics have been explored in pancreatic imaging. So many studies, each one with a different aim. So it's difficult then to take a reliable radiomics model that can really apply in a clinical practice. And again, main limitation, the lack of prospective studies using radiomics. Radiomics has been shown to be reproducible when are the same reader or different reader assessing the same scanner. But the problem of radiomics is the reproducibility among different type of scanner. This is even higher on MRI because we still acquired MRI imaging with different sequences, with different parameters, and all of them could affect the reproducibility of radiomics in clinical practice. I think the EuSoMII have done a great job to assess the quality and assess the evidence on radiomics studies, and also improving the evidence of the radiomics application through two main documents, which is the CLEAR checklist. It's the checklist for evaluation of radiomics research, and this is mostly a guideline for authors who want to report a radiomic study, and also to reviewers who wants to assess the quality of a radiomic study submitted to a manuscript. And the second one is the matrix, the methodological radiomics score, which assess the quality of published radiomic studies. Both of them are freely available. You can access to those manuscripts and to the relative tools using the QR code present in this slide. Now let's move to workflow optimization. Workflow optimization is another problem that we have in abdominal imaging, especially in abdominal MRI. Here I'm presenting you some of the sequence that we acquired during a standard imaging acquisition for the upper abdomen. We have many sequences, T2-weighted sequences, in phase, out of phase, MRCP, so MR cholangiopancreatography, diffusion, post-contrast images, and this is only performed, this protocol, with extracellular contrast agent. And if we perform a study like that, the total scan time is around 30 to 40 minutes. And there are some of those sequences which are characterized by long acquisition times. For example, MRCP sequences 3D could go from 3 to 5 minutes, and also diffusion-weighted images can go from 2 to 4 minutes, impacting the total scan time and also the compliance of the patients undergoing MRI. So what could help in this setting? There have been application of deep learning to speed up the reconstruction of the sequences and to reduce the overall timing of the MRI images. Those deep learning applications have been most commonly applied to diffusion-weighted images and MRCP, using deep learning algorithm to reconstruct high-quality images from undersampled K-space data. And this allowed us to acquire the faster scan with 2 times faster, up to 4 times faster, and improving also the diagnostic quality and reducing the artifact. So deep learning could have a role in clinical practice to reduce the scan time and improve the image quality. Let me show you this study example using deep learning and AI to improve the quality and the scanning time of MRCP. And here we have 2 different images. One was acquired with a standard MRCP, which is about 8 minutes of acquisition timing, and the other is an MRCP with application of deep learning, which was only 2 minutes. What we can observe from these images, we can observe a reduction of the image noise, an improved spatial resolution, better delineation of the of the biliary tract, an enhanced image quality, and also an accelerated acquisition. I think this will be really important for the abdominal radiologist to decrease the timing of the acquisition protocols on MRI, especially when we have to acquire those sequences. And also, those deep learning algorithm can correct motion or breathing artifact, improving the overall image quality. So those are examples of advantages for workflow optimization. Traditional scan time could be up to 35 40 minutes, while deep learning, we're able to decrease the scan time, improve the signal to noise ratio and the contrast to noise ratio, reduce the artifacts, improving the patient comfort, compliance, and also improving the spatial resolution. Those, I think, are all expected applications that we will see, especially integrated in the newer MRI scans. And then automatic measurements. Measurements are part of the abdominal radiology workflow. Thus, that could be requested for example, volume of the liver, volume of the spleen, of the other abdominal organs. Volume of the liver is, for example, very important in patients undergoing hepatectomy, either right myo right hepatectomy to assess the future liver remnant. And this is taking time because organs are large, because programs needs to segment the liver in all slides. AI and deep learning could help us speed up in this operation using UNet models. I'm sure Anarita will go in details regarding the architecture of the models applied to segmentation. And right now we already have segmentation tools that can be integrated and used to segment abdominal organs. One of that is total segmentator, which can be applied either to CT or MRI images and allows an improved segmentation accuracy because manual segmentation has problem too of inter-reader reproducibility, has problem of long timing to perform segmentation, reduced variability, decreased segmentation time, and also the segmentation can be affected by the image quality. So the improved segmentation and automatic segmentation open also a big area of opportunistic screening. What are opportunistic screening? Are all the information that we can take for risk stratification and detection of unsuspected presymptomatic disease. Abdominal imaging and abdominal scans have a lot of information within it that oftentimes we don't look at that. We have information on the fat distribution, we have information on the atherosclerotic disease, on the bone structure, we have information on the presence of hepatic steatosis. So automatic segmentation can open the road of opportunistic screening and AI-assisted screening. For example, what has been explored currently is the mineral bone density, and as for the assessment of osteoporosis, the visceral fat, which was closely related to metabolic syndrome and diabetes, the muscle area, which is an indicator of sarcopenia associated with prognosis, especially in patients with tumors and with undergoing chemotherapy. The liver for automatic detection of steatosis. Remember that about 30% of the general population will have hepatic steatosis, and also arterial calcification in the abdominal aorta and superior respiratory vein, celiac trunk for the assessment of atherosclerosis. Those are all information that we can automatically provide and extract using AI-assisted screening. What are the current challenges? First of all, there is a fear for additional radiology workflow. We should translate all this information in our radiological reports. Then also, all this opportunistic screening, if we detect a disease, there is also the problem of additional follow-up, additional patient workup for the assessment of the presymptomatic disease, the problem related to the AI algorithm and diffusion, and also the variability across scanner, which still remains one of the most problematic points for the widespread of the AI application in clinical practice. This is a really recent study published on January 2025, which used AI application to provide a biological age model based on CT images. And this is really impressive what the author have done in this study. They assessed CT images for bone, muscle, fat, aortic calcium, and specific organ, and using AI, they constructed a model and which was associated to the prognosis of the patients. So this model was trained on a massive number of patients, more than 120,000 adults undergoing CT images. The model, interesting, outperformed demographic data for the prediction of the survival of the patients, and the prediction of longevity was higher compared to demographic data. So probably we will get many more information from a single CT scan of the abdomen in the future year. And then structural reporting. This is an important point for abdominal radiologists. Structural reporting have been discussed as a way to implement our reports, to implement communication between clinicians and radiologists, and also to extract data that are more reproducible. But structured reporting are not widespread. There are studies that report that less than 50% of radiologists in the United States are using structured reporting in clinical practice. This is because structured reporting is hard to be like written. It's more time consuming. It requires a structural assessment, and sometimes it's not easy to transform challenging description in a structured reporting. So while there are advantages on structured reporting compared to free text reporting, still the number of reports that have been written like that it's low. How can we use AI? We can use AI in this context to create a structured reports starting from a standard narrative text. AI could be either used to change the reports, and especially this is done using the large language model from a standard text to a structural assessment, or it can be used to pre-fill a structured reports or reports the negative findings, improving the also application and widespread of structural reporting. This is what have been done in current study, using free text reports and using large language model as a prompt, and then to create a structured reports. So AI could be used to generate structured reports from unstructured reports, extract the data from the free text, generate impression from radiology findings, and also creating a structured reports from imaging data. This is also important for the application of system like the LIRADS, in which we can create and we can ask AI to create LIRADS category based on the description of imaging findings. Moving to the end of the presentation, let's look what are the current application of AI. This is an update on the current AI application in radiology based on commercially available products and also their evidence and their basis. And the author selected 173 AI products which are commercially available. What is interesting to note, looking at the subspecialty, the largest part of the AI application in commercially available products are in neuro and in chest. Abdominal application are about 9% of the current commercially available products, so quite low. And also looking at the main functionality, most of applications of the AI are based on quantification and lesion detection. The important is the evidence on the basis of this application, because when we have to deal and install a new application in our PACS, we should look at the evidence and we should look at many important points regarding the use of the AI. And this author showed that still 34% of commercially available products have no scientific publication on basing on their results. This is an improvement compared to the 2020 analysis, but still represents 1/3 of all the application. And if we look at the level of evidence that we have in current literature, most of the evidence are based on diagnostic accuracy studies, while we have still low higher evidence such as patient outcome efficacy or therapeutic efficacy. So we still, as a radiologist, I think we still have to investigate more the evidence, especially in the abdominal field. The author provided a website in which you can freely access. It's called AI in Radiology. This is a register of all AI products that are being commercially available and approved by either European regulation or FDA. And when you click on this website, you can access using the QR code. You will have all the available information on the products. Those are all information that you should know before using your the AI product in your practice. Some of those information are important. There are information related to the data characteristics of population, the type of input, the type of output of the AI software, the technology that was integrated in the AI software, the processing time, which is also an important point for our practice. The regulatory phases, if it is marked by FDA or the European Union, and the market, the pricing, and also the evidence on that. If there are already available peer-reviewed papers based on the performance, or if there are not yet available peer-reviewed papers on the performance of the AI in specific settings. So before looking at AI products, my suggestion is to ask all these characteristics in order to understand if the products will be important for your practice, will be applied in your practice, and it will apply to all the type of AI current practice. So to conclude, to take home, I think AI will be in all our practice point, starting from the order of the examination to the procedure by speeding up the application of and the acquisition of the sequences, especially on MRI, to improving our quality of the evidence and improving our quality of the images that we are looking in our clinical practice, till to the part of image reconstruction, lesions identifications, lesions diagnosis, and also finally communication of imaging findings and structural reporting. So I think AI will radically change the way how we work. This will be integrated in the radiology practice. We still have to have clear in mind what are the advantages, what are the limitations, and what are the rooms for future improvement in the AI and our clinical point as a clinical radiologist. So thank you so much for your attention, and really happy to, if you have any question, to discuss at the end of the presentation.
Thank you very much, Roberto. Your presentation was very comprehensive. I'm very glad that we already received a couple of questions. If you didn't have time to type your questions, go to the Q&A and you can write down your questions there. We will address all of them at the end of the session, so also after the next presentation. And now I'm very pleased to welcome Dr. Anna Rita Pecchi to give the next lecture. Dr. Pecchi is an associate professor of radiology at the University of Modena, Reggio Emilia. She's a radiologist at the University Hospital of Policlinico of Modena, where she leads the imaging diagnostic in hepatobiliary, pancreatic, and gastroenterological oncology. She's an active member of EuSoMII and CIEM. Her work focuses on oncological and liver transplant imaging, as well as AI and radiomics in oncology. And now I'd like to invite Dr. Pecchi to discuss the technical aspect of radiomics and the applications in abdominal imaging. Thank you very much.
So thank you, Federica, for kind introduction, and thank you very much, EuSoMII and ESGAR, to this joint webinar more interesting. So my disclosures and my topic is AI in abdominal radiology technical perspective. In the last years, as Roberto introduced in your relation, the role of AI bringing in new opportunities for early diagnosis, accurate characterization, more precise treatment, and better outcome. And in particular, AI act in different topics: detection, automatic segmentation, characterization, and outcome. AI is an emerging technology in the field of medical imaging, and the term AI describes computer systems that mimic human cognitive function, such as learning and problem solving. In particular, the core of AI is algorithm. Algorithm is an ordered and defined sequence of steps or instruction designed to solve a problem or to perform a task. And the artificial intelligence algorithms were machine learning and deep learning. Machine learning is a form of AI that allows the system to automatically learn without programmation. And the learn is on the basis of a large amount of data that training machine learning and improve its performance through experience. We classify the machine learning in different algorithms, supervised when are based on labeled dataset, unsupervised when are unlabeled, based on unlabeled dataset, and semi-supervised learning trains an algorithm by using partially labeled dataset. Deep learning is a complex subcategory of machine learning and is based on convolutional neural network. Deep learning uses convolutional neural network to detect features significantly associated with the lesion to further derive an outcome. So also to training deep learning, it's important to have different data set annotated. Convolutional neural network are deep learning models specialized in image processing. In the first phase, the network are training and about information on dataset. So after training, the network automatically learn to extract features and recognize patterns. An important use of this network is in segmentation and also in distinction from liver and tumor detection. An example of this network is EuNet that use an architecture encoder-decoder to codify the features and to detection. In summary, the fall of AI is based on machine learning, deep learning, and convolutional neural network. And these different applications were used in different steps of image analysis. First, denoising, image quality improvement and dose optimization. Secondly, image analysis, segmentation, detection, and classification. And third, to predict outcome with radiomic analysis. The first step is denoising, image quality improvement, and dose optimization. In the last year, are introduced different deep learning reconstruction protocols that in CT imaging aim to reduce radiation dose, maintaining adequate diagnostic accuracy. These protocols are based on deep convolutional neural networks that provide less noise images with reduced radiation dose setting. And the image quality improved both in terms of signal-to-noise ratio and contrast-to-noise ratio. An example of this deep learning reconstruction protocol is residual neural network, or ResNet, able in CT images post-processing to reduce dose radiation and to improve image quality. In this example, you can see in the middle and in the right images the use of deep learning reconstruction. And you can see that this algorithm reduces the noise, maintains high contrast spatial resolution between hepatic metastases in 5 segments and surrounding liver, and also decrease in complex radiation dose with two different levels, high in the right and medium in the middle images. So these deep learning reconstruction algorithms are used also in MR imaging. And in MR imaging, we have the possibility to increase signal-noise ratio, or in alternative, to maintain a signal-noise ratio and to reduce the imaging time. These algorithms, replacing mathematical design models such as parallel imaging or compressed sensing with a deep learning-based technique. And we have different examples from different manufacturers, GE, Canon, and Siemens. But it's important attention, because deep learning reconstruction may change the imaging features of lesion, and it's possible obscure small lesion. An example, in the middle images, you can see the use of deep learning reconstruction, and you can see the high spatial resolution, the possibility to detect the small cystic lesion in the body of the pancreas, compared to other imaging acquired in the right and the left, acquired without deep learning reconstruction. The second point is based on image analysis, in particular in segmentation, detection, and classification. In particular, segmentation is the base of different processes important and fundamental in diagnosis, treatment, and to evaluate progress of disease. Segmentation in radiology is the process of dividing an image into well-defined region or structure of interest, with the aim of automatically or manually isolating and extracting anatomical parts or pathological process. and segmentation. It's possible to obtain segmentation with the classical method based on mathematical or statistical characteristics, or deep learning based method based on convolutional neural network. An example of automatical and semi-automatical segmentation in liver living donor transplantation to segment liver for volume analysis and to prepare transplantation. And these semi-automatic and automatic segmentation are safe and easy to use, with a strong correlation with the graft weight. And the principal advantage of this technique is the speed, because in a few minutes the reconstruction is able to perform volume evaluation. To analyze the performance of automatical segmentation, we use DICE similarity coefficient that compare the performance of manual and automatical segmentation. And in A, you can see no overlap between manual and automatical segmentation with the coefficient 0%. In the middle, you can see partial overlap between two different segmentation techniques with 50% of coefficient. And in the right image, you can see a complete overlap of two different type of segmentation with a high coefficient. In this slide, an example of deep learning to automatical segmentation. Deep learning training is based on a dataset, and the first important step is to acquire CT scan image from dataset, which are then partitioned in training in different topic: training, validation, and testing set. So after image acquisition, we perform a pre-processing to enhance generalizability and normalization of image with the different steps. But the core of this algorithm is U-Net encoder and decoder technique joined to inception blocks for multi-scale and multi-level feature extraction. The use of U-Net network with inception blocks consent to obtain tumor segmentation maps with an high accuracy and EuSoMII value. The limitation of this automatical and deep learning network are first, availability of dataset, open access to training this model, and also to this model usually perform well on the training dataset, but their performance in different clinical settings remain to be demonstrated. And also these deep learning models are more complex and often operate as black boxes, which present significant challenges for clinical practitioners who wish to comprehend the rationale behind the segmentation outcomes. Also, We have also the extreme variability in tumor lesion about size, about texture, and heterogeneity. And also in the last year, we have reported importance of peritumoral microenvironment in predictive radiomic analysis and the segmentation. In some case, it's important to extend the segmentation, include also peritumoral microenvironment. The last point is to predict outcome with the radiomic analysis. The underlying hypothesis of radiomics is that advanced image analysis could capture additional information not visible at human eye and not currently used, and more specifically that genomic and proteomics patterns can be expressed in terms of macroscopic features image-based. So, radiomics refer to the extraction of high-dimensional data from radiological images and has been applied in particular in oncology to improve diagnosis and prognostication related to outcome of disease. Radiomic studies in oncology usually is important for classification tasks and prediction of clinical outcomes in terms of survival. And radiomics address two key needs: non-invasiveness and assessment of spatial temporal heterogeneity of the lesion compared to biopsy that is invasiveness and with spatial temporal limited detect. Radiomic workflow. In this slide, you can see the study design of radiomic workflow and the different steps in study design of radiomics, in particular the selection of patient population to define a study endpoint is more important, and to acquire image for analysis, to extract features, to select feature, and to building a model and validation the model. It's important to collect clinical data in a repository for analysis and to join clinical data to features extracted from radiomics analysis to building a model. Image acquisition and the first step of radiomics, and it is important to standardize imaging protocols to collect data homogeneous. And the second step is image preparation and to extract image anonymized in DICOM format and pre-processing image before radiomic analysis. Pre-processing is important in particular in qualitative imaging because the intensity units are arbitrary and normalization method may be needed to standardize the future extraction. Pre-processing is based on intensity discretization and voxel side resampling. And also is based on filters. And in this setting, Image Biomarker Standardization Initiative recently introduced a standardized set of filters to enhance reproducibility of radiomic. In this slide, an example of common filters applied to images. The next step is annotation and segmentation. Segmentation can be performed drawing ROIs on the tumor, on the regions of the tumor, and in the peritumoral habitats. And the ROIs can be delineated manually, automatically, or semi-automatically modality in 2 or 3-dimensional data. And automatic segmentation is faster, but radiologist is important to ensure accuracy and to check the result of automatic segmentation. The next step after segmentation is future extraction. Future extraction is the final step before model building. And radiomic features are handcrafted. The algorithm used to generate the features are designed or chosen by data scientists. This is important because consequently it may be possible to interpret radiomic signature compared to deep learning analysis where we don't have the possibility to interpret the result. The features are different in different level of complexity. We have morphological features, first level features, second order features, and semantic features. And the one important limit of features is interpretability and complexity. And color mapping help to associate features to tissue biology. Finally, features, it's important feature selection because not all features add information to the model, and it's important to select the more important features, and we have different modality to selection the features manually, feature correlation, feature stability, dimensionality reduction, filters method, and others. So after features selection, we building the model with the statistical instrument, and the model validation. It's also important after model creation, and the model validation it's performed in new test data from usually from another institution, but if the validation is in our institution, it's important to validate the data in another set of data. As Roberto reported in your presentation, we have different guidelines in radiomic workflow, and in particular image biomarker standardization initiative guideline for standardized and extraction features. Clear guideline to perform optimal good paper about radiomic and metrics to evaluate the value of paper of radiomics. In conclusion, AI is demonstrating the capabilities and the resources to revolutionize abdominal imaging, improving efficiency and accuracy, and revealing its predictive role. But there are still limitations such as heterogeneity, limited data generalizability, and the lack of standardization, and also black box nature of AI models. But to overcome this limitation, efforts are needed to standardize and homogenize data, and new supporting technologies to make processes more usable and immediate. Only in this way it's possible to translate this assumption into concrete evidence of personalized medicine for patients. Thank you for your attention.
Thank you very much, Anarita. It was very comprehensive. I totally like that. So maybe I didn't introduce myself before. I'm Federica Vernuccio. I'm from the University of Palermo, and I will start now with asking one question to Roberto. So I can see we had already several questions, and I will start with first. I think it's for both, but maybe Roberto can start. In what ways can explainable AI techniques be advanced to address the black box problem in complex tasks like multi-organ segmentation in abdominal CT and MRI?
Thank you, Federica. First of all, thank you for all the attendees that have followed all the webinar right now, and also thank you for the one who are making the questions. I think AI, first of all, myself, I'm a clinical radiologist, so I'm less in how the model is developed, but I think to really understand the valuable in clinical practice, it is important to understand how AI is working, how AI is arriving to a conclusion, and also open the black box of AI and see, for example, how the AI is finding the lesions and which lesions get the attention of the AI. So explainability of AI will be really an important point in order to let all the radiologists know the power of the AI and understand why AI and how AI could help in our clinical practice. And this can be done in any cases. Segmentation is one of that. Segmentation is a task that, as a clinical radiologist, it's really difficult and annoying because it takes a lot of time. So understanding how the segmentation works, what are the margins of the organs, what are the best phases to segment the organs, and what are the best valuable of AI algorithm, I think it will be really important for our practice.
Thank you so much. So I'll follow with the next question. On benefit of time, the following would be the last question. Then don't hesitate to discuss. This is for both of you. We can let Anarita answer first and then see what Roberto has to say also. I think it might be interesting. So this question is, how frequent AI radiology research is conducted at your hospital? Are they always affiliated third-party commercial AI developers?
In my hospital, we have more research about radiomics, in particular radiomics, because we collaborate with oncologists in these topics, in different organ evaluation, in particular in breast, in abdomen, and in the brain. And I think that in our hospital, radiomics is the more AI application in research. And in particular, in predictive role of radiomics in oncological patient to survival, to outcome in the treatment, and also in some case with radiomics we perform radiomics to detect gene predisposition and gene mutation in oncological patient. And this is very, very interesting.
Sure. Yeah, that's one of the popular domains, and it's really like where we should see some concrete applications soon, right? I think.
This is a really interesting question, especially regarding to developer. I think we are not really developer of the AI, but we will be the user of the AI. So, for example, in my hospital, we are conducting studies right now, mostly on application in emergency radiology, fracture detection, and also chest X-ray. So not really related to abdominal imaging. but we are conducting research how we integrate the AI platform in our clinical practice, which are the improvement for the patients, and which are the improvement for the diagnostic performance. Not really affiliated with the developer, but we are connecting how we ourselves as a user can use the AI to improve our clinical reporting and to improve our clinical practice.
Nice. So following that, the question asked also if there are always affiliated third-party commercial AI developer within this kind of research.
Not in my experience. They are delivering the software, but our research, we are working in an academic center, so we do independent research on the performance of the AI using our clinical practice. So at least in my experience, what we are conducting right now are independent research, academic research on AI, not really linked to the development.
Also for me,
Yeah.
in my routine, we perform in particular research study about AI, and we have less experience in clinical practice of this setting, this application.
Perfect.
I
Yeah.
think
So
that-
we see
Yeah, and
Federica, sorry. Go on.
I think that it's important, even if there is no direct link, maybe Roberto or Anna-Rita like provide feedback to the developers, not? Is that correct?
Yes, the feedback, I think we should provide independent data analysis. So all the studies that are performed by the developer are, of course, in a point of showing how good is AI, but then clinical practices are there. We have different patients, different protocols, different applications. So I think the feedback is important to provide with independent research and also speak with them because of course they have the technology, they have the expertise to improve the AI. So I think it's the role of users and the interaction with development will be really crucial in the next future to speed up the widespread of the AI in clinical practice.
It's also important to have different medical figures or specialists to collaborate because when I use AI, I collaborate with medical physician, engineering, and in clinical practice, it's difficult to have these colleagues near to for aid to obtain the result. And also the time, because for this application, it's a long time spending, and it's in a clinical setting, it's difficult to use these elements because the time is long.
Totally. So I think you touch really important points there. So the need for collaboration, having these people that are like in between radiology and in between the like in the middle of the technical and the clinical personalities, so that they can act also as an interface between both worlds, and also having the clinical independent research that will allow us as doctors really know if this will effectively have positive or negative changes not for patients. So I'm sorry, we're a little bit over time. We have to conclude. I would like to really, I really appreciate your participation, Dr. Cannella and Dr. Pecchi. Your presentations were wonderful, and I think they were really educational for everyone participating here. I would like to share my screen now for everyone to see we have just a little disclosure. The urogenital radiology session was postponed. So next session will be in December the 9th. In AI in radiography practice, we have two wonderful speakers there also, so don't hesitate to join us. With the QR code you can already register, and if not, don't hesitate to follow us on LinkedIn and the other social network to keep updated. So thank you so much everyone for joining. Thank you the speakers and my co-moderator for having this session. It was wonderful to have you all here.
Thank you, all the participants. I also congratulate Dr. Pecchi and Dr. Cannella for this, and I was very glad to moderate this with Mercedes. And hope to see all of you, all the participants, also at the next webinar.
Thank you, Federica.
Thank you very much. Good evening.
Thank you.
Thank you.
Good evening, everyone. Bye.